All right, guys, I just want to make a real short video here about Lamictal. So, Lamictal, or for the fancy people in the room, Lamotrigine. Yeah, so the thing about this is, I personally like if I don't like to use the word hate, but I hate this medication. So basically, uh, there's this rash. So rash. Let's just start talking about rash. It's very scary. It's called Stevens Johnson syndrome. It's a maculopapular coalescing pustule, a lot of derm words for basically you get blisters all over your body, and then the blisters get bigger and they link together, and then all of your skin falls off and you can die. So let's not have that. But severe SJS is actually called TEN, and I honestly forget what those letters even mean at this point. And I don't even remind me. There are some pictures that I looked at back in medical school that are still in sort of a blacked out part of my brain. But anyways, so um, Lamictal, Lamictal um, has not changed many lives. Now, I don't want to be unfair, and like you find somebody who says like Lamictal, you know, really straightened everything out and everything's so much better, and I love it, and of course keep those people on it, and God bless. I have a feeling those people were kind of doing fine already, but God bless. But it's not a very strong antidepressant. It's technically, I mean, its original FDA approval is for, epilepsy, and it's not even amazing at that. And the thing is, it's one of these narrow window meds. So the window is like the med works to the med kills. And we want that to be a really big distance. Really, 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 really big. But in Lamictal, not so much. It's one of these ones that we do have to monitor, like lithium um, and Depakote and Tegretol and Clozaril. It's one of these ones that we do have to worry about because the blood level fluctuates so much. Now, it's not, we don't usually get a lamotrigine levels. That's more of an epileptologist, neurologist kind of thing. They usually want trough levels of the lamotrigine to determine, if it's adequate to actually protect you from specific seizures and stuff. That's a bunch of complicated stuff that I never really learned because it's not my specialty. But for our sake, what we got to know is greater than 48 hours off. Um, you have to retitrate. And knowing about the titration of Lamictal is super duper important. So the most simple case. So that usually like when you research this, you come up with a graph that has like 12 or 9 different segments, and it looks like it's this really complicated thing. But for the vast majority of the time, you want to do 25 milligrams, and you want to do that for about uh, 2 weeks, and then 50 milligrams, 2 weeks, and then um, 100 milligrams, 2 weeks, and then 150. Now, if anybody here believed me just now, here's your learning moment. We just killed somebody. No, I'm just kidding. We might have put somebody at risk for SJS. So, no, you really do need to be careful. So, 25 milligrams for 2 weeks, and then you can go up to 50. And then I would go up to 75. And then 100. And then you can safely go to 150 or 200 probably after that. But yeah, so it takes between 6 to 8 weeks here. You can look up different guidelines. They'll all be roughly like this for the simple case. Where it gets complicated, and this really shouldn't happen in psychiatry, is when you pair it when the patient is taking other medications with it, most notably Depakote or Tegretol. And if somebody's taking Tegretol, just come find me and be scared, because that medication sucks. It's got like a lot of demons in its closet. Everything's going to go wrong in your Tegretol patients. So you see carbamazepine, or however you say that word, carbazepine, carbamazepine. I don't know how many syllables it even has. You see that word on a chart, and you just come find Dr. Connolly, because we're gonna need some help. But anyways, lamotrigine don't play nice with Depakote Tegretol, and they don't play nice in opposite directions. And I think that honestly, the reason why this gets taught so much is because people find it interesting more than it's actually useful. But long story short, with Tegretol, you're chewing up too much. So with Tegretol, you increase dose faster. And with Depakote, you're not you've inhibited your liver enzymes a bit, and you need to go slower. And could you imagine going any slower than this already? It's already pretty slow. So in the Depakote, the first 2 weeks is 25 every other day. I mean, so basically, just don't use it with Depakote or Tegretol, and then you don't have to worry. So make sure when you have a patient on Lamictal that they are not also taking Depakote or Tegretol, and let's not have any crazy rashes. And if a patient on Lamictal reports a new rash, you always have to take it very seriously. And the most classic beginning of SJS rash is a rash that starts near the center mass of the body and spreads out, maculopapular, which is basically just blotchy red blotches. And they usually don't itch, but if they itch, that doesn't mean throw a party. It's not SJS. You'd probably still be worried about it, but usually, typically SJS wouldn't itch, and then the rash would keep getting worse and worse, spreading around the whole body, and it would start to blister, and then more and more of it would start to blister, and the blisters would start coalescing into each other, and then eventually you have what's called skin sloughing, which is like the worst word in the world. Like, this word gives me nightmares. Like sloughing, skin sloughing. So let's not have any of that in our hospital, please. And so basically, the reason why I'm going through all this is because a lot of patients will come in and they'll be like, "Yeah, I take Lamictal 200 daily. Sure, whatever. They'll say that, right? But do they really? Do they really though? You got to make sure, because if they quote unquote take Lamictal 200 milligrams daily, but they haven't been taking it, like if they've taken a week off, 5 days off, a year off, and they remember like, oh, but their medication is Lamictal and their dose is 200. Like, we could be setting the patient up for a disaster that we're liable for, and that's going to be no fun. So you really got to verify that they're actually taking the dosing, especially with schizophrenics. I often do not trust them. I want to see some data that something's been picked up from a pharmacy. So what I'll usually do when I get the call overnight, the intake call, if the patient's reporting that they were on Lamictal, I'll usually just order 25 milligrams to start, because that's a safe dose to start at, and await verification. Now, we don't want to go in the other direction and have people that were faithfully taking their Lamictal, and then they come to our hospital and we screw them over by not giving it to them for like more than 2 days, and then they have to retitrate. That's not what I'm about. So we want to be timely, and we want to be careful. And thanks for listening. I love you guys. Go team. You guys make the hospital work. And PMHMP for life, yo.